Okay. Thank you, Ambion. So now we can proceed. So today I have kept only obstetrics questions, and gynecology I'll be taking as a separate section tomorrow, right? So today we will take only obstetrics questions. So as usual, I have divided the questions into two separate groups, one-liners and the clinical ones, right? So firstly, we will take the one-liners, and the very first question was about puerperal pyrexia. Now, puerperal pyrexia, again, the word pyrexia means fever. So, yes, we are discussing some entity related to fever, and the definition of pyrexia, puerperal pyrexia, is like after 24 hours of delivery, right? So, any high grade fever, usually we take it at 38 degrees Celsius, right? So any fever of more than or equal to 38 degrees Celsius after 24 hours of delivery is taken as puerperal pyrexia, right? So this time duration is very important here. It has to be after 1 day, or you can say 24 hours after delivery. Clear? And then of course there is rise in temperature, and here it is not like that it is related to only puerperal causes. It can be because of infection anywhere. It can be in chest, throat, breast, urinary tract, pelvic organs, legs, or related to the delivery area, that is cesarean or perineal wounds, right? So any site in the body can be a reason for this fever, which usually manifests after 24 hours after delivery, right? So this is puerperal pyrexia. So I think that's a very straightforward definition. You have to just mug it up. There is no concept behind this. So more than 38 degrees Celsius after 24 hours of delivery, right? So there is not much to discuss in this thing. Now there is another question: ideal number of antenatal visits. Ideal number of antenatal visits. Now I would seek your answer. So let me see what answer do you have marked in this particular question. Yes, Ambien, what's your answer for this ideal number of antenatal visits? Very good, right? So here you have to remember two terms. One is ideal and second is minimum, right? So ideal and minimum. Like ideal is the one, it suggests the number of visits which is needed for proper care of the mother and the developing fetus, right? So for antenatal care, you can say. So that is ideal, which is recommended. Now many times we have seen that the pregnant lady, she might be working or she might be living, at the very far skirts, so she won't be able to come as per the ideal plan. So what we do, we have devised a minimum plan, like at least come for this period of time. So what is the minimum number of antenatal visits? So minimum number, again, very good, MVN. So these are antenatal visits. Clear? So if someone asks you minimum, then it is 4, and if someone asks you about ideal, then your answer should be between 12 to 14, and yes, that is the right answer to this MCQ, right? So 12 to 14. Now this is the whole pattern, like how we calculate, like how we say that, like what time you have to come in ideal or minimum. So if we talk about the minimum, the first visit has to be made sooner after the detection of pregnancy. So as soon as the pregnancy is confirmed, that will be the first visit. Then okay Utkarsh, right? Then the second visit has to be made between 13 to 26 weeks, right? Then the third visit has to be made between 27 to 34 weeks, and the fourth visit anytime between 36 weeks till term. So again, this is very important for you to remember, because this is one important concept. Like, sometimes they will ask you number, and sometimes they can even ask you the time period. So you should be perfect with the time period as well. Like, if we are talking about the 4 visits, then what actually is the time when we have to call that pregnant lady? So as soon as the pregnancy is confirmed, then 13 to 26, then 27 to 34, and finally 36 weeks till term. And when we say about the ideal number of visits, which is usually 12 to 14, or if someone asks you a single value, then your answer would be 13. Okay, Sai Chand, don't worry, I'll definitely take NEET PG reviews. Let me finish this all FMG recalls first, and definitely I already promised you that I'll take the reviews in second half of July, right? So I'll definitely do that. That's my promise. Don't worry, right? Now, about the ideal number of visits. So yes, the range is between 12 to 14, but if someone asks you about the exact value, then that is 13. So how 13? Like, in the initial 7 months, the lady is supposed to come every month. So that will be 7. Once every month for the first 7 months, that is 7. Then in the 8th month, she have to come every 14 days. So in the 8th month, she have to come every 14 days, means like twice a month. So that will be 2 visits. And in the 9th month, she have to come every week. So that will be 4 visits, right? So if you just sum it up, it will come out to be 13. So 13 is the exact value, but for... Okay, Saichan, don't worry. Utkarsh, as a human, I'm trying my level best. Okay, so I don't think so, but yes, I'm just trying level best, right? So this is how we can get that value of 13, right? So if someone asks you the exact value, then please write 13. And if the range is there, like as we saw in this particular question, then of course you can mark 12 to 14. And I'm again requesting all of you to please learn this segregation as well, because it might be a question next time. You never know, right? So like we always say, better focus on PYTs, like the topics in detail rather than the questions, right? So this is one important topic which everyone should know. Clear? So this is how we have calculated the I marked +2. Utkarsh, I couldn't get you. +2 in what? I think you might be talking about some other question, I guess. Okay, so this is... Okay, got it. Right. So this is the segregation of antenatal visits. So please remember the values, and more importantly, if you can just read, you can just memorize the segregation, it will be far better for you, right? So please remember this. Clear? Now, next question is about outlet forceps, right? Outlet forceps. Now, if you look at the term proper, the term here is outlet. So again, it just gives you an idea, like what is the position of the fetal head. Now, the fetal head is in the perineum, right? So fetal head is on the perineum, and that is the scenario where we apply the outlet forceps, right? So again, I have kept a image just to help you out. Now the fetal station is taken as 0 when the fetal station is at the level of ischial spines. So I think most of you must be knowing that these are the ischial spines, right? So these are the ischial spines. right? So if the fetal head is at the level of ischial spines, we give it a 0 level. So fetal head is said to be at a station of 0. If you go upward towards the pelvic inlet, the value will keep on becoming negative, right? And if the head is descending down towards the perineum or the introitus, you will give a positive value, right? So this is how we give we define the station of the fetal head. So this is the station of the fetal head. Now if I'm saying, say, +5, it means the fetal head is somewhere near the perineum, and that is the position when you will apply an outlet forceps. So you can say the fetal head is at the outlet of the female genital tract, or what you call the introitus. So in that scenario you will apply the outlet forceps. And to remember, so for outlet forceps, the fetal head is at or on the perineum, number 1. Number 2, the scalp is visible at the introitus, right? So you can see the fetal scalp, the sutures, and this is like without separating the labia. And we can, as I told you, like we can see the sagittal suture in the AP diameter or the right or left position, right? So this is the indication for application of outlet forceps. So the word is itself suggesting that the fetal head is somewhere at the outlet, right? Or that is actually known as the introitus or perineum. Clear? So I'm just taking one outlet forceps in this particular question so as to not to mix up the things, right? Medico vertex x +2 or +3, yes. Plus, if it is +5, that is of course a better answer, right? If you have got +5, that is the perineum, that is the better answer in terms of outlet forceps. Now Medico wrote like +2 or +3. Now here, especially in cases of +3, you can apply low forceps, right? So if you see +3, +4, you can go for low forceps, but if it is specifically on the perineum, you have to answer outlet forceps, right? So for the time being, if the fetal head is on perineum at the introitus, apply outlet forceps. Clear? So that is the concept of outlet forceps. Again, there are low forceps, mid forceps. I'm not going into all those because that will just mix up the whole thing. So, sorry, no, okay. In option second, +3 was given. Okay, you are saying that here it was +3, right? So if it is like this, again for +3 you can apply low forceps. Clear? For +3 you can apply low forceps. Again, for station +2 you can also apply low forceps, right? And for this, if I just write it down like here, you can also apply low forceps, and for engaged head you can apply mid forceps. Clear? So I think this will just help you out. So let me use another color here. So this is outlet forceps, right? So this is how you can remember the options. And the takeaway point is that if the fetal head is on the perineum or the introitus, you have to apply outlet forceps, right? So the fetal head is somewhere out at the outlet of the female genital tract, so apply outlet forceps. So in that way you can remember this particular answer. Okay, yes, and very honestly I would say that it is little difficult, and because it is more practical. Once you are into the ward and if you have into the labor room, and if you have done all this, then it is quite easy to remember, because usually theoretically going with Okay, Utkarsh, I will try my level best. Don't worry. Don't worry. Thank you. I'll try my level best, right? So, yes, I was saying like that if you are into labor room and if you have done all these procedures or if you have assisted all these procedures, then it is quite easy to remember. But theoretically, we have a tendency to mix all the things up. So for the time being, I will request you to just take one entity at a time, and that is the outlet forceps. And for outlet forceps, you have to just remember one thing, that if the fetal head is on the perineum or at the introitus, we will apply outlet forceps. And you can also say if the sagittal suture is visible. Clear? So that is the indication for outlet forceps. Clear? So for the time being, just take outlet forceps and don't take all the entities together, otherwise you will surely mix up. Okay, now I think this is a very easy question and this doesn't need any sort of discussion. Most of you must have marked it right. So exclusive means nothing except breast milk. Okay, so yes, this is quite repeated. Yes, Utkarsh, you are absolutely right. So exclusive breastfeeding has to be done for 6 months. It means for the first 6 months of life, you don't give anything extra except the mother's milk, right? So that is exclusive breastfeeding, right. Then marker for ectopic pregnancy. Again, this is very easy. So that is beta human chorionic gonadotropin, so beta HCG. Now I have just kept one image so as to help you to understand the ultrasonographic picture of a normal pregnancy and an ectopic pregnancy, right? So this is on the left is normal and this one is ectopic. Clear? Yes, gentlemen, again it's a repeated question. So in normal, you can see that the gestational sac is within the uterus, right? So it is within the endometrial cavity of the uterus, right? But what happens in ectopic, the uterus is empty, right? So uterus is empty, the endometrial cavity is empty, and the gestational sac is developing somewhere else. It can be, as in this particular case, it is in the cervix. It can develop in fallopian tubes or any other part. So that is ectopic uterus, right? So the classical word will be empty uterus. So the gestational sac is not in the uterus, it is somewhere outside except the uterine cavity or the endometrial cavity, right? So this is the concept of ectopic pregnancy. Now, next question, early cord clamping. Early cord clamping is done in, yes, anyone? Early cord clamping is done in. I think again this is a very basic question, and early, very good. So it is done in Rh negative mother, and yes, very good, everyone is right. Utkarsh, Medico, MVN, everyone is right. Now why we do early cord clamping in Rh negative mother? Because we want to reduce the feto-maternal leak, right? So we want to reduce the feto-maternal leak. Clear? So we want to reduce this feto-maternal leak. So we clamp the cord earlier. Now there is a mnemonic for this, and you can remember, like, especially RH incompatibility, that everyone answered right. Then fetal asphyxia. Then third important is diabetic mother, right? So these are three important indications which everyone should remember, right? So Rh negative, asphyxia and diabetic mother. In these three conditions especially, we do early cord clamping. Clear? So please remember at least these three conditions, right? Chalo. Next question, contraindication to ventouse or what we call vacuum assisted delivery. Now what is the contraindication to ventouse or vacuum? Very good, Utkarsh. So this is preterm baby, right, or preterm fetus. And for this, again, the important is preterm fetus, which is usually less than 34 weeks. Apart from that, there are many other conditions, but in relation to the question, the answer is preterm fetus. And this is an image on the right side, and this is how you can see this is usually the suction cup, and this is applied to the fetal head, and then the baby is assisted in coming out of the genital tract, right? And there may be a development of chignon, right? So if you see here, this swelling is known as chignon, and that is because of application of the vacuum cup, right? So this is ventouse or vacuum assisted delivery. Clear? So never apply a ventouse to a preterm baby. Instead, in such cases, we can try a forceps, right? So this is in short about ventouse. So these were all one-liner kind of questions which I have compiled. Now we will go on to the clinical type of questions, right? So here one question was that a 17 weeks pregnant lady had a BP of 144 by 94 millimeter of mercury, and what is more important here, that she don't have proteinuria, right? So here you have to Medico, yes, you are right. Okay, no problem, Utkarsh. Like here you have to notice three things: 17 weeks pregnancy, raised blood pressure without proteinuria. And yes, the answer would be chronic hypertension, right? So this is known as chronic hypertension. Now what is this gestational hypertension? Gestational hypertension is that if there is hypertension in pregnancy beyond 20 weeks, right? So if the hypertension is detected in pregnancy after 20 weeks, then it will be known as gestational hypertension. And since in this question it is only 17 weeks, so we will not mark this option. Yes, Medico, you are right. Yes, after 20 weeks anytime. And then what is this preeclampsia? If along with this patient is having proteinuria, you will call it preeclampsia. Clear? So gestational hypertension, only raised blood pressure after 20 weeks. Preeclampsia, raised blood pressure plus proteinuria after 20 weeks of pregnancy. So this is how you will remember all the three terms and their definition. Okay. Utkarsh, it can be like, see, the basic, the core of the question will remain about these concepts only, and yes, the presentation might change, like the stem of the question may be different, like the blood pressure is checked again after some time and it was found to be elevated. So yes, you can write like that. So this is first reading, and you can say after some time BP was measured again, okay, and it came out to be 144 by 95. Chalo. So it means, okay, Medico, I agree to that. So there are two readings at an interval, but both the readings were elevated, and this was at the 17th week of pregnancy. So this suggests that there is chronic hypertension. And yes, I think that's a better framing of this question, because what can happen, like first, the first value maybe high because of anxiety, or some whenever you tell the patient to do something, so there might be that anxiety that might raise the blood pressure. So take the blood pressure, note down the first reading, give some time for the patient to relax, let the reading relax. So maybe after 2 or 3 hours you can check the blood pressure again, and if it is again elevated despite rest or relaxation, it indicates that yes, the first value was correct, really the patient is hypertensive, right? Yes, perfect, I agree to that, Utkarsh, agree to that. So this is a classical scenario for chronic hypertension. And yes, the core knowledge which you should get from this question is that if a lady is having high blood pressure before 20 weeks of pregnancy, you have to label it as chronic hypertension, right? So again, in obs and gynae, you have to be very crystal clear with definitions, because these are very very mildly segregated terms. So there is very basic difference between different terminologies, so you have to be very perfect with that, right? So again, I have just taken a table, and this is for chronic hypertension, and where it is said that the blood pressure is more than 140/90, that is hypertension, and that is either present before pregnancy or diagnosed before 20 weeks of gestation. So that is very important, before 20 weeks, right? And more than 140/90, that is hypertension, right? So this is chronic hypertension. And if the blood pressure is high in case of pregnancy after 20th week, that is gestational hypertension, and of course there is no proteinuria. And if there is hypertension after 20 weeks, Baba Bairagi, gentlemen, right now I don't have any batch as such, but if there would be any, I'll definitely convey to you and through my WhatsApp number or other groups, right? Right now I don't have any batch as such, right? So if there would be any, I'll definitely convey it to all of you, right? So okay, coming back to the topic, gestational hypertension, the blood pressure is high after 20th week of pregnancy, but again without proteinuria, right? So without proteinuria. And if the lady is having high blood pressure after 20th week and with proteinuria, you will simply call it as preeclampsia. And if there is convulsions, then will it become eclampsia, right? So that is the basic terminology with respect to the hypertensive disorders of pregnancy. So I would request you, please try to be perfect with the definitions at least. And we have seen over the years, every time you have 1, 2 or 3 definitions in the exam, right? So please try to be perfect with the definitions, right? So this is okay. Now coming to the next question. During labor, the head of the baby was delivered, but the shoulder was stuck. Now what you will call this? There is the head has been delivered, but the shoulder is stuck behind the pubis symphysis, so that is known as shoulder dystocia, right? So the shoulders are stuck behind pubis symphysis, okay, clear? So this is known as shoulder dystocia. Baba Bairagi. Thank you, Saichand. Right? So this is a classical description for shoulder dystocia. Now I have kept images just to help you understand what actually shoulder dystocia is. You can see that the head is almost out, but the shoulder is impacted. Now this is pubic symphysis, right? So this is pubic symphysis, and you can see here that this is the anterior shoulder. Okay, so this is the anterior shoulder here, and this anterior shoulder is stuck behind the pubis symphysis. Okay, so this is known as shoulder dystocia, and this prevents the descent of the baby. If it is impacted, the baby cannot move further, right? So we can do a Mack-Roberts maneuver for the management of shoulder dystocia. And what actually we do here, we tell the lady to flex the hip joint and the knee joint, right? So the knee comes something like this. So the hip has to be flexed and the knee has to be flexed, and that is this demonstrated by number 1. And then in number 2, the attending doctor, it gives a suprapubic pressure, and we try to dislodge this shoulder something like this. So we give a suprapubic pressure. So first is the flexion of the hip and the knee joint of the lady, and the lower limbs are slightly abducted, and then yes, absolutely, Utkarsh. The second one is suprapubic pressure, and we try to dislodge this anterior shoulder, which is lying exactly behind the pubic symphysis. So if we give pressure, it might dislodge and it might make the way for the normal vaginal delivery, right? So this is the Mack-Roberts procedure. So firstly, you have to flex the hip and the knee of the patient with slight abduction, and then give a suprapubic pressure, right? So this is shoulder dystocia. Then next question, a 40 weeks lady with breech presentation was having labor pains. Now what should be the requirement before initiating delivery of such a patient, right? So she is in breech. So what should be the things should be ready with you before starting delivery of such a patient? Now, there can be a normal mechanism of labor in breech delivery, but you should be ready for any possibility or any requirement of emergency cesarean section, right? So one should be ready for this. This should be always there, because you don't know when you might need or when you might have to switch from the normal vaginal delivery to the cesarean section. So before trying any malpresentation, whenever you are trying for normal vaginal delivery for any malpresentation, backup should be there for cesarean. That's very important. Although we try for normal vaginal delivery by all means, but at times finally we have to resort to the cesarean section, right? So that is very important. So if you have a lady with the breech presentation, try for normal vaginal delivery, but keep the things ready for emergency cesarean. So again, these are the different types of breech. If the lower limb is extended, if you can see, if the lower limb is extended, okay, like this is known as frank breech, right? So this is frank breech. The lower limbs are extended. If the lower limbs are flexed like this, right? So you can see the lower limbs are flexed, then this is known as the complete breech. Clear? So this is the complete breech, right? So both lower limbs extended, frank breech, both lower limbs flexed, complete breech. And if it is dropping down something like this, this is known as footling, right? So this is known as footling breech, right? So these are the three different types of breech: frank, complete, and footling. Okay, so be ready for a cesarean. The possibility is that the normal attempt might fail, so be ready for cesarean. Now I think this is very basic question, and the presentation might looks very long, but it is not like that. So a lady presented with vaginal bleeding and it is at the 10th week of gestation. And when we did USG, we found multiple cystic spaces, right, within the uterine cavity. There was no fetus, and beta HCG levels were markedly elevated. Now what should be done here? So before jumping on to the treatment part, you have to make a clinical diagnosis first, that what actually this case is. Now there is pervaginal bleed at 10th week, and there are multiple cystic spaces in the uterine cavity. There is no fetus as such, and beta HCG levels are extremely high. This goes in the favor of a diagnosis of, I think this is very important, very easy. So that is molar pregnancy, right? So this is molar pregnancy, or what you call H-mole. Clear? So this is a classical description for molar pregnancy. And whenever we are saying multiple cystic spaces, so you will find this kind of impression on ultrasound, and this is known as snowstorm appearance. Clear? So this is the classical snowstorm appearance description, and beta HCG levels are extremely high. So this is molar pregnancy. Now come to the second part of the MCQ, like what you need to do. So what is the management for molar pregnancy? It is suction evacuation. Okay, so for molar pregnancy we will do suction evacuation. Sometimes you might find the word suction curettage, so that is same. So suction evacuation should be done. So again, I have kept ultrasonography of the molar pregnancy, and that is showing the classical cystic lesions in the uterus. That is all the snowstorm appearance, right? So this is, you can see the multiple cysts. These are all cystic spaces, right? So this is a classical snowstorm appearance, or what you call the cluster of grapes. So snowstorm or cluster of grapes appearance for molar pregnancy, and this is how we will do the suction evacuation, right? So this is all molar pregnancy, and then we are doing a suction through the cannula, so that is suction evacuation, right? So this is suction evacuation. Suction is like negative pressure and just taking the things. Evacuation means evacuating the content from the uterine cavity. So this is suction evacuation for molar pregnancy. This is very important. And after that we have to do follow-up by measuring beta HCG levels. So follow-up is also necessary here. Okay, so suction evacuation followed by serial measurements of beta HCG. Clear? So this is about molar pregnancy. Now moving on to the next question. Again, this is a very easy question and repeated many number of times. So you will see a lady with 32 weeks gestation, right? And there is sudden onset of abdominal pain and vaginal bleeding. And when you examine the patient, you find that the uterus is tender and loss of fetal movements. Now what will be your diagnosis? Now again, this is a case of antepartum hemorrhage. Okay, so this is a case of antepartum hemorrhage, right? And what is important here, that tenderness is a keyword. So tenderness of uterus. So the moment you have this kind of presentation, yes, anyone, what can be the answer here? What can be the answer here? Anyone? Antepartum hemorrhage with tender uterus. The answer has to be Abruptio placentae, which is also known as accidental hemorrhage. So Abruptio placentae, right? So again, I have kept an image here just to show you. Now this is the normal attachment of the placenta. You can see this is the attachment of placenta, right? So this is the placenta, and then this is the umbilical cord. Clear? Now this is all placenta. Now here you can see that the placenta has detached from its bed, right? So this is the placenta, and this detachment is known as placental abruption. So here you can see this is the detachment. Clear? So that causes bleeding, in fact. So that is Abruptio placentae. Clear? And this is all blood here. This is all blood because of this detachment, right? So this is blood. So this is Abruptio placentae or accidental hemorrhage. Clear? And again, a classical term for diagnosis is tender uterus. Fine. So just make sure that you find this word, and then you can straight away jump to the answer as Abruptio placentae or accidental hemorrhage. Now going to the next question. A married lady of 28 years presented with vaginal spotting, or you can say vaginal bleeding, right? So what is the first investigation which has to be done in this case? Yes, anyone? I'm just waiting for the answers. If someone can answer this. A married lady having vaginal bleeding, the age is only 28 years. What is the first possibility which you will try to rule out? Yes, anyone? I'm just waiting for your answers. Anyone? Okay. Okay, no problem. I'll tell the things. Now here, see, if a lady is young, she is married, there is possibility that, very good, yes. So if a lady is young and married, there is a possibility that she might be pregnant, and there is a condition known as early hemorrhage in pregnancy, right? And this is because of abortion. Clear? So what you call miscarriage, it is also known as miscarriage, right? So there is a possibility, especially in a young lady, we should rule out the pregnancy which might have resulted in abortion or miscarriage, right? So therefore you will check out whether pregnancy was there or not. So rule out pregnancy. Clear? So firstly you have to rule out pregnancy, and of course in a 28 years cervical carcinoma or endometrial carcinoma is not a possibility. So the first thing is to rule out pregnancy, because if you know, we have many types of abortion. One is threatened, then inevitable, incomplete, complete, and finally missed. So there are different types of abortion as such. So this is the scenario. It might be the scenario in such a young lady who is married, right? So the possibility might be there that she is pregnant, and now in early pregnancy she is having hemorrhage, which might be because of that abortion or miscarriage. So we have to rule out this thing first, that is there any abortion or miscarriage, right? So do a urinary pregnancy test first if a young lady comes with vaginal bleeding. Clear? So that is the concept behind this. And again, in cases of inevitable and incomplete, the cervical os will be opened. Clear? So there are only two types of abortions in which the cervical os will be found to be open. In all other varieties, the cervical os will be found closed, right? So This is very important because many times you have a case history for these abortions, and the only differentiating point which is helpful to us to make a diagnosis is the status of cervical os, whether it is open or it is closed. And then it is only in the threatened abortion that the fetus is live, it is dead here, it is dead here, it is dead here, and in majority of the cases it is also dead here, right? So the fetus is alive only in the threatened variety. So cervical os closed, fetal cardiac activity present, and vaginal bleeding, think of threatened abortion. So right, this is how we can make a differential diagnosis of the different types of abortion. Now in the missed type of abortion, the fetus has already died, so there is no cardiac activity. It has already died, right? So this is missed abortion. Clear? So this is again a very important diagram, I guess, just to differentiate the different types of abortion. So this might be the possibility in this particular case, and therefore we have gone initially for urinary pregnancy test. Perfect. Chalo. Then next question. Now, a lady is in labor, right? And the fetus is in occipito-posterior position, right? So this should be position. Clear? So the fetus is in occipito-posterior position. Now what is more important here, this lady has a past history of lower segment cesarean section. She have already lower segment cesarean section in previous delivery. Now what is the best management? Now what should be done in this case? Yes, I am waiting for your answers. Anyone? Previous delivery with cesarean section, now having a baby with occipito-posterior position, and what need to be done now? Yes, anyone? I am waiting. Wonderful, Utkarsh. Wonderful, wonderful, wonderful. See, if there is a history of previous cesarean section and in the subsequent pregnancy, if there is occipito-posterior presentation, better go for cesarean section. Don't take the risk because there is possibility of uterine scar rupture. So the better thing is go for cesarean section. Don't take unnecessary risk. Yes, if this would have been a primary case without any past history of cesarean, I would have definitely gone for option C, that is trial of normal vaginal delivery, right? So this is in case no previous history of cesarean section, right? So I'll definitely go for this if there is no history of previous cesarean section. But in case if there is any history of previous cesarean section, please do cesarean section again. Don't take unnecessary risk, and that is what is being recommended. So in occipito-posterior as such, there is no need of cesarean, but cesarean should be done in cases such as preeclampsia, post-cesarean pregnancy, big baby, right? So these all cases need cesarean section. Otherwise, uncomplicated pregnancy, you can go for trial of normal vaginal delivery first. But if the case is complicated, no need to take risk, right? So especially in cases of preeclampsia, post-cesarean and big baby. So in all these cases, go for cesarean section, right? And this is how, in the image I have shown you how occipito-posterior presentation position looks like. So this is the sacrum of mother. This is pubic symphysis. Clear? And we are looking at the patient from below, right? So this is the patient's right side and this is the patient's left side. Clear? So you can see here, this is the anterior fontanelle, what you call bregma, right? So this is anterior fontanelle, and this is the posterior fontanelle, what you call lambda. Okay, and this is the metopic suture in between the two frontal bones, and this is the occiput of the fetus, right? So you can see the occiput is occupying the posterior part or the posterior quadrant of the maternal pelvis. So it is known as Occipito-posterior presentation, right? So in this case, it is, since it is towards the right side, so we will use the word right occipito-posterior. So that is how we do the nomenclature or the position of the fetal head, right? So this is right occipito-posterior. And again, if there is a past history of cesarean, please go for cesarean again rather than taking risk. So I think this is enough for today's class, and as I request you always, if there is any query or if there is anything you want to discuss, this is my WhatsApp number, right? So you can just drop a message here, and tomorrow like 10:30 p.m. we will go with gynecology, right? So tomorrow 10:30 p.m. gynecology recall. I'll request all of you to come and just spend some time with me. We will discuss the questions, right? So I'm very sure you might have enjoyed the session. So see you tomorrow. Thank you. Good night. Bye-bye.